Okay, you can hear me? So this morning we're going to spend the next 40 minutes talking about special pathogen preparedness in the emergency department. So aside from trauma, this is my other uh, passion and area of expertise. I spent some time working with the U.S. Centers for Disease Control on particularly special pathogen preparedness. What's happening?
Just the wire.
I'll try not to breathe, and then it will work. Okay. All right. So, when I say special pathogen, what do you think about?
Anthrax.
Anthrax. Why do you think of anthrax?
Well, maybe, I don't know. Somebody's preparing it or somebody's before. Chlamydia.
Chlamydia? Okay. Okay. What else? What do other people think of? What did you say?
Plague.
Plague. Okay. COVID. Maybe. We're going to talk about it. Anything else? These are all great ideas.
A novel virus.
A novel virus that we haven't even decided yet. So I think of special pathogens as something that are novel or re-emerging infectious agents that are at the center of the Venn diagram of hazardous, like anthrax, meaning that if you catch it, you're going to have a lot of morbidity or mortality. Infectious, meaning that something that doesn't take a lot of infectious agent particles to cause infection. And then communicable, meaning it spreads really easily from person to person. So viral hemorrhagic fevers like Ebola, some coronaviruses like MERS, and we would have considered COVID in that category at the beginning when we didn't know much more. Maybe novel influenza right now. So easily transmitted, don't have a lot of medical countermeasures, and that high mortality, and that there's a need for rapid notification and action. So we're going to speak a little bit about some of these classifications. So viral hemorrhagic fevers are kind of what everybody typically thinks of. So several different phylogenetic categories, but Ebola, Marburg, and Lassa are probably some that people are most familiar with. Maybe Crimean Congo hemorrhagic fever, which is becoming more and more routine. And then hantavirus has actually been in the news recently. So the blue are person to person primarily. The black are rodent or vector-borne transmitted, but can spread person to person. The problem with viral hemorrhagic fevers is that their case definition is very broad. So if you look at the symptoms, fever, headache, muscle pain, diarrhea, things like that, like that's the majority. As we learned yesterday in the trivia, abdominal pain, fever, infectious symptoms are some of the most common presenting complaints in the emergency department. So that's not enough for us to be very concerned that a patient may have a viral hemorrhagic fever, but also they must have an epidemiological risk within the 21 days before their symptom onset. So travel, healthcare work in a place that has a known infection, some kind of rodent or vector exposure. Unfortunately, sometimes these patients, we don't know what their exposure was, and that's one of the main problems. If we think more about respiratory pathogens, some of the coronaviruses like SARS, MERS, novel influenza I know is in the news a lot right now. Plague, pneumonic plague was mentioned, hantavirus, and then we think of extensively drug-resistant TB in that category just because we don't have a lot of countermeasures. Unlike viral hemorrhagic fevers, MERS and some of these coronaviruses, the case definitions are a lot more complex. And so it really requires a lot of nuance and knowledge to be able to ask about the symptoms. So it describes both severity of the illness, but also their epidemiologic risk. So that is what makes you think more or less that this might have happened. So that makes it a little bit challenging for us in the emergency department where we have to sift through these public health case definitions, and that can be really challenging when we're in a rapid fire environment where we're trying to get through to the next patient, but still protect ourselves and our our patient population. We also think about some of the pox viruses, smallpox in particular, but mpox is also something that in the news lately that we can also maybe consider in this category. Less so because of it's in the center of that Venn diagram, but more so because of the impact that we're seeing on the world right now. So, what are some reasons that you think that these viruses could and bacteria could be emerging or re-emerging in our current modern era? Okay, bioterrorism. Hopefully not. Hopefully that is like the lowest. Yes. Yeah, for smallpox, most likely, if we were to see a smallpox event, that would be a bioterrorism event. What else? Hmm. So here I am. I came here from the US to Sweden. I brought all my pathogens with me. Hopefully, I didn't have any, but yeah, we're having a very global world, right? So we can really easily get place to place. And so that's a risk. What else? Yeah. So what might happen in like a natural disaster that would make this a problem? Yeah, absolutely. So if you ever participate in a humanitarian response, when you're setting up like a refugee camp or something like that, the first things you're thinking about are water, sanitation, and hygiene, and then measles vaccination. So because people are not vaccinated, including in the US, we're having a huge resurgence of measles right now. You're putting all these people in cramped quarters, and measles vaccine is one of the first things that you want to do. What else? Yeah, yeah. Right, absolutely. Yeah. So polio, measles, like we're seeing these viruses more regularly, and even in places where polio was eradicated because of geopolitical reasons and hesitancy, we're seeing more and more polio and measles. And then another reason is expansion into the environment. So as we become more urbanized, we kind of like contact our environment more regularly, and so we're contacting vectors and other things that may be a natural host of a pathogen. No one mentioned climate change. This is probably the biggest reason we're seeing a lot of this because we're seeing expansion of vectors, change of vector environments. So places that normally didn't carry the mosquito that transmits dengue or malaria are now able to have that. So in the U.S., that's an example is that we're seeing more and more transmission of locally of malaria and of dengue from those mosquitoes actually being in our southern states.
Do you consider malaria and dengue as part of this effort?
Not as much, but it just demonstrates that we're as the climate is changing that we're having more and more of these events. Crimean Congo, though, viral hemorrhagic fever in Europe, that is definitely due to climate change.
So do you consider in certain states malaria as a reasonable differential in the patient, not traveler, that comes to deal with a fever you can't explain? Do you consider
Yeah.
malaria?
Yep, we have to consider malaria, especially in Florida and in Texas, where we've had local transmission. Yeah.
Just a curious fact, but our Sweden's last malaria case, we had malaria for many hundred years, was 1933, and then it was eradicated because of housing and sanity, basically. But the mosquitoes are always here.
Uh-huh. So you did you eradicate mosquito in the urban environment or just the malaria itself?
No, usually because the living standard was so high that people got their separate rooms and the mosquitoes didn't, infect and reinfect. And then you separated livestock from housing as well because they lived closer otherwise. So both Finland and Sweden were eradicated basically by hygiene and welfare standards.
Interesting.
But we have 4 vectors that still could potentially carry malaria.
Wow.
An example in Sweden for climate change-based infection is Borrelia.
Mm-hmm.
Much larger season Borrelia infection. It's going to boil out in winter now.
In all throughout the country, or is that in only certain areas where the tick?
Mostly in the southern
Uh-huh.
Doesn't really.
Okay. This is a extreme example of urbanization. When I worked for the CDC, I went to Angola to investigate one of the largest yellow fever outbreaks in the world, actually. And one of the reasons was because of a breakdown in trash infrastructure because of like the volume of people that were living in the capital city. And there was just piles and piles of trash like this, all of which is excellent mosquito breeding grounds. And so things, the impact that humans have that we don't even think about, like these small things, can really create a huge difference for infectious disease transmission. And then our porous borders. The world is very small. It's easy to get place to place. And having those porous borders enables humans to contact each other, which is a great thing, but also puts us at risk for exposure. So we're emergency physicians. We're thinking about abdominal pain and chest pain and trauma all the time. Why this stuff seems kind of like not in our wheelhouse. Why should we think about it? The problem is there's like a lot going on in the world every year, and we are actually at risk of seeing it and experiencing it. So just in the past couple years, we've seen new things like Ebola, Marburg, Lassa, H5N1. We've seen old things like Nipah, MERS, yellow fever come back. And so these are real things that are happening around our world. This is an example of outbreak alerts in the news over the last week. So 1,400 outbreak alerts. There's one from Sweden about H5N1. So these are things that are actually happening every day. If we think about Ebola, this year alone, 14 cases in Uganda. We've seen 2 pretty big Marburg outbreaks in capital cities in Rwanda and Tanzania. And so these are places that people go to. So you can easily get from Kigali to Europe or the US. And so these are actual like real threats. Lassa fever, very common in Nigeria, endemic. We had 1 case imported in the US last year in Iowa. Really random, middle of the country state where you would not expect to find Lassa. So things that we need to be thinking about in the ED. This is about CCHF, so Crimean Congo, likely due to climate change in southern Europe, but you never know. If malaria mosquitoes are here in Sweden, it may be only a matter of time before you may have something that can transmit CCHF. We've also been thinking about hantavirus. I don't know if you guys, this has been a US-based news story probably, but Gene Hackman and his wife, the actor, were found mummified in their house after a week of being deceased, and his wife was found to have died of hantavirus, which is in the US primarily transmitted by rodent droppings and exposure to an inhalation of rodent droppings. Kind of weird and random that she died of that, but another hemorrhagic fever. H5N1 definitely on our minds right now in the US. We've had many cases of human H5N1. Nothing that has definitively been human to human. So these are mostly spillover events. Cows, chickens, things like that people have been exposed to. But Sweden has had an avian influenza outbreaks for the last year. So culling birds here. So I don't know. We were just discussing the egg prices. Egg prices in the U.S. are really high right now because of avian influenza, but sounds like yours have been a little bit preserved, which is good. One thing that we're doing is wastewater monitoring. So we've done this with COVID, now also with H5N1, just to get a sense of when there's something circulating in the community. It's not perfect. These could be cattle, birds, other things. It doesn't necessarily mean it's human, but we know that the virus is at least in the community. So this is something we've been doing for about a year now. So you can see California and a little bit in our East Coast, there's some positive cases. These correlate where we've had human cases, so likely there's undetected human cases as well. And then just a brief mention about Mpox. So last year declared a public health emergency due to clade 1 in Africa. Since then, we've had clade 1 in the US. Also, y'all have had it in Sweden. So one of the first the first country to have clade 1 identified outside of Africa. So definitely something that's has a little bit higher mortality, a little bit higher morbidity, and more easily transmitted. So something that to think about as well. This is the world flight patterns, a lot coming to your region and my region as well. So really easy to get anywhere in the world in 12 to 24 hours. So easy for someone who doesn't know that they're infected with a pathogen to get on a plane, develop symptoms when they arrive home. The reason why I want you to care about this is to protect yourselves. So healthcare workers get sick. We've seen this time and time again in outbreaks of special pathogens. So, and even if your patient doesn't have a special pathogen, you don't want to get COVID or influenza, measles, chickenpox. You don't want that from your patients. So identifying patients who are at risk of having an infectious disease is useful regardless of what it is. But we know in Ebola outbreak, for example, in Sierra Leone, 21% of the healthcare workforce of the whole country was infected. So that's imagine 21% of your workforce being taken out by a pathogen, right? We also saw a nosocomial transmission cluster in Texas. So a return traveler, presented to the emergency department several times before he was identified. And that led to nurses in Texas getting ill. So that's like a never event. We never want that to happen, right? And then we know from coronaviruses as well, disproportionately affecting healthcare workers. So MERS, cyclical infection, usually in the Arabian Peninsula, 20% of the cases are healthcare workers. So this is something that people are being exposed to and again. So it's something we need to think about. Same for SARS when that happened in Canada in 2003. All of the next cases who were exposed to the index case were healthcare workers. So respiratory therapy, ICU. Some people didn't even have direct respiratory care of the patient. So this is something that we really need to think about. We also know that the emergency department is an amplification zone. So we don't want to get sick, and we don't want all of our other patients to be sick either. So this is an example of an imported MERS case in South Korea. One person traveled from the Arabian Peninsula to South Korea, went to the emergency department, and infected all of these people from sitting in the emergency department waiting room. One person led to 39 cases. One super spreader from those cases led to 76 cases from being in the emergency department. So this is a real thing that can happen. And because of this, a lot of Southeast Asia and Asian countries have really ramped up how they take care of these patients. So how do you protect yourself and best help your patients? Do you all have protocols in place? What do you do?
We dress up.
Okay.
Yeah, with protective glasses, masks, plastic covers.
Just all the time? How do you know when?
Well, fevers and coughs.
Okay. For all fever and cough?
More or less.
Okay.
Well, at least we should.
Okay.
Yeah.
Well, we should too, but I know people aren't doing that. Yeah. How many of you are masking for every patient encounter? Anjana's? I am. Okay. Nobody else? Are your nurses masking? Yeah, nobody's. Are your patients masked? Okay. Yeah, for us, same thing. Everyone's coughing on each other in the waiting room, and it's, just kind of terrifying. Since COVID, I continue to mask for all my patient encounters. I can't believe how much time I just breathed everybody's air, so, and I've been much healthier, actually. I haven't got ill as much, so. But I think you bring up a really important point about the identification process. So in the world of special pathogen preparedness, we use the mantra identify, isolate, and inform. 3 steps for us in the front line, and that's all we have to do. So we don't have to worry about all these complicated case definitions. We don't have to know what's happening all over the world or in our own region so much, but we have to be able to assess a patient's symptoms and risk, remove them from the general population, and then get help. So identification is all about how we assess risk. What I recommend is using a universal symptom and travel and exposure screen at all of your ports of entry. So that would be the gold standard. So the symptoms, new fever, cough, and rash. Those are like kind of the hallmark symptoms for a lot of these infectious diseases. And we use our electronic medical record, which is Epic. I don't know, I think Epic is maybe around here in Denmark. Okay. Epic has a built-in symptom and travel screen in all of their builds. So if you have access to Epic or whatever electronic medical record you have, you can build this into your triage so that it happens universally, every patient, every time. New fever, cough, or rash, if they do, they should get at minimum a mask. And then second, any travel or unique exposure based on their symptoms and current risk. So where have you traveled in the last 3 weeks? Any new activities? Historically, we would ask any travel outside the US in the last 3 weeks. Now the US is kind of a risk factor, so more like regional travel or other new exposures. Like for areas that are very agricultural, we're asking about exposure to cattle, chickens, things like that. And then if we use the electronic medical record, we can really ensure compliance by our triage staff so that every patient gets asked these questions, because we don't want to miss this for our most critical patients. We don't want to like skip some patients because we don't think they're sick. If we routinize this, we get used to doing it and we make sure that we don't miss anybody. And then we want to let our triage staff know what the next procedures are for the next step. So it's not enough to just, yes, they have a fever and they traveled to Uganda right now, but we need to know what they need to do. The reason why this shall be universal is that we looked at the case definition for MERS. It's super complicated. It's vague for viral hemorrhagic fever. We can't worry about interpreting all these case definitions while we're working in a busy shift. So we need something streamlined. We need something easy to apply. And like we mentioned, even if a patient doesn't have an emerging or special pathogen, they might have the flu, COVID. You don't want that transmitted to yourself or to your waiting room anyway. So it's important to isolate them regardless. At Emory, at the height of the West African Ebola outbreak, we looked at cases, the actual diagnosis of people who were returned travelers with a fever, who were persons under investigation for Ebola. None of them had Ebola, which is good. They had influenza, they had diarrhea, malaria, different gastroenteritis, things like that. So still infectious, a lot of them. So still important to have identified. And then, like you mentioned, we don't know what the next big thing is. We don't know when the next COVID is going to happen, and we don't want to be on the backside of that. We want to be prepared, and we want to be ready. Our next step then, after we've identified a person at risk, is to isolate them. So a couple things that we can do to isolate. Simply masking is like the best next step. Super easy to do. People generally are okay being masked. In our setting, people are a little bit less happy to be masked, but I feel like maybe in your setting, people would accept a mask, hopefully, and keep it on in the waiting room. I don't know. I'm getting the sense people might be more happy than Americans are to be told what to do. And then ideally in like a pandemic setting, having a split triage flow between infectious side and non-infectious side. In a busy ED that's already overcrowded, this is really hard to operationalize. We don't use this right now, but we have in the past in pandemic flu situations at the height of COVID in the US. We did do that. We want to quickly get these patients roomed. So we don't want them in the hall stretcher. We don't want them in the waiting room. We want them into a room where they're at least ideally in like an airborne room while you're figuring it out, but any room is fine. And then thinking about their PPE and their isolation precautions depending on what you're worried about. It's important to choose your PPE based on the precautions, based on transmission, so what you think they have, what's the transmission dynamics, but also healthcare worker familiarity. So if you think this is a viral hemorrhagic fever and you've never put on a PAPR, like this is not the time to be putting on the PAPR because you're likely going to contaminate yourself in the doffing process. So gown, gloves, mask, eye protection work just as well, and that's something that we're much more familiar with. In terms of the precautions, depends on the mode of transmission. Remember, we have droplet nuclei for our airborne pathogens, droplets, which can spread through respiratory and direct contact, and then our direct contact pathogens. We should be using universal standard precautions for every patient every time. That's hand hygiene, so soap and water versus alcohol rub, gloves, mask, and eye protection. You all told me you're not masking, so I know that nobody's using universal standard precautions every patient every time, but you should. And safe bodily fluid and sharps handling. And then we add on to that our transmission-based precautions. We should really be using good signage so that all the staff, nurses, anybody going into the room knows what they need to wear. So contact precautions, gloves, hand hygiene, gown. Droplet is masking, and then of course the respirator for airborne. Unfortunately, we are really bad at hand hygiene. They've studied it. Like this was a little bit old, but this is 29% compliance in all the patient encounters. That is really gross. So we need to be better. So I don't know how to encourage that, but hand hygiene needs to be reformed every patient before and after every time. Some of the reasons that people have reported poor adherence is just location based. They're too busy. They perceive a low risk of acquiring infection. I get all the other things, but the perception of low risk I think is really a fallacy. We really need to think about that and perform that both for ourselves and our patients.
Just explain.
Yeah.
Hand washing versus alcohol.
Yep.
What's the difference? Is it enough with just alcohol or is it enough with just hand washing? So that you don't have anything you see on your hands.
Yeah, so as long as your hands aren't visibly soiled and you're not worried about C. diff, then alcohol rub and soap and water hand washing are considered equivalent in terms of infection prevention. But if your hands are visibly soiled, you're concerned about C. diff, things like that, then obviously we need to use soap and water. Did you have a...
Well, I was taught the opposite, that soap and water will merely take away a fraction of the bacteria on your hands. So alcohol rub is the way to go.
It's because we don't perform hand hygiene correctly. If we perform the WHO standard hand hygiene, 30 seconds, happy birthday, all the different areas, they should be equivalent, but nobody washes their hands that way ever. And then that's it, right? So if we're going to wash our hands in a less than standard way, alcohol rub would be superior. But should we do the gold standard WHO method, we should be okay. Norovirus is the big one. So yes, usually my standard method is if they have a GI situation, I'm going to use soap and water. And probably alcohol rub too, just to be extra careful. But yeah, I think it's probably best practice.
What is the US stance on watches? I mean, in Sweden we are not allowed to wear watches. That's really a thing. If you see a doctor with a watch, they are probably psychiatrists or orthopedic surgeons who touch the patient.
Okay.
Every other doctor.
Can you have anything else below nothing below the elbow?
No
Rings,
no watch.
wedding
We
ring.
don't have codes anymore.
Okay, good. Okay. Ooh, we got caught. Okay.
In the US, in the movies and even in photographs from even studies, if they publish studies and have some original photograph, you see doctors
ED doctors wearing watches.
Yeah.
What's the stance on it? Do they say watches isn't that dangerous? It's okay to have it.
Yeah.
Maybe we in Sweden we are like, oh, watches that's so dangerous, and it's not true. Or what's like the evidence behind not wearing watches?
No, I mean, that evidence, so the question is evidence about like things below the elbow, watches in the clinical setting. The evidence supports what you all do. So there's like all of this is like a foamite, anything below the elbow, watches, rings, nail polish, long nails. Nails is like actually the most well studied of all of it, and nails are gross. So anything that like the length of the nail is like the single most like risk of like transmission patient to patient and a lot of like nosocomial outbreaks. But certainly like hair, even like people with long hair, things like that, anything can be a risk to transmit. So I think your method is much better. We don't really wear white coats anymore, luckily, because they were really gross. But we do wear what Anjani is wearing right now, which is like a fleece. That's like kind of the standard emergency doctor uniform, scrubs and that fleece, which those sleeves are pretty gross. So she washed it recently, so it's okay. But people wear rings, people wear watches, but we really shouldn't. But I think our infection preventionists are like fighting much larger battles that haven't trickled down to the watches and other things yet, which is like unfortunate. But due to Americans not liking to be told what to do, it's hard to tell them what they can and cannot wear in the healthcare setting. So I would continue your practice. I think that's best. There's also a risk in the pre-hospital environment. So say a patient gets picked up at the airport being sick and was brought to your facility. We want our pre-hospital providers to take the same considerations, take the same symptom and travel screen that we are doing in the emergency department, but also there's additional precautions from, like this is an example of a biosafety transport ambulance, so it's like fully containment wrapped. But even like using the air and exhaust fans, separating the driver compartment, masking everybody, things like that to help protect the pre-hospital personnel. We also want to think about our ED flow. So you may want to think about what room you might use for a patient if you're near an airport or something, like you're practicing in Stockholm or one of these bigger centers that may have more international travel. Like a patient comes back from Uganda with a fever. Where's your isolation room? How are you going to get them there? What's on the floor on the way to the room between the waiting room? Is there carpet? Is it cleanable? Like maybe not always the shortest distance is the best, but some place that goes past less other patients or less other risk of exposure. So, or outside. Yeah, that's something that we use. We actually bring a patient out and around through our ambulance bay. And then inform, which is calling for help, basically. So once they're in the room, we need to get the basic history. We may need to do some stabilization, but otherwise, let's get some additional information. Let's get an expert on the phone. And so for us, we have a lot of people that we would call. Infection prevention and infectious disease are our primary assisters in this. So infection prevention and infectious disease will liaise with our public health to help us understand, is this actually a risk? Are we overblowing this? What's the next step? How do we test? Like, how does this get to the lab? Things like that. We also want to let our ED leadership know. You don't want them seeing on the news that you had a suspected Ebola patient in your ED and they didn't even know about it. Your public health authority, communications at the hospital leadership, and any other personnel who need to be notified to implement the infection prevention measures. So having a phone tree, as you're thinking about a protocol, I recommend everybody have a protocol so that you at least have something to go off of, and part of that can be the phone tree of who you're going to call and what order. And then what next? Like, let's treat our patient. Like we said, a lot of other diagnoses are more common. Supportive care and antimicrobials are the mainstays of treatment for most of these conditions anyway. So fluids, electrolytes, antimicrobials. And then we have an ethical, and in the US, we have a legal obligation to stabilize and treat our patients. So we can't just put them in the room and be scared of them. We need to use what we know to feel empowered to care for them in a safe way. We also need to think about kind of long-term and downstream complications. So thinking about waste management, disinfection of your room, how you're going to manage that depending on what you decide about that patient. And then in a steady state, training in PPE and your protocols. And so that can be both steady state, but also just-in-time training. So you have a PUI in your ED. Let's think about like reviewing the protocols really fast. And who do you train? Is it everybody in the ED? Do you have super users? Is it infection prevention? Like, depends on your facility and your staff. This can be a really stressful time. So certainly if you think you're taking care of a patient with a viral hemorrhagic fever, that can be like really upsetting and stressful to you. I know at the beginning of COVID, people were staying in hotels rather than going home to their families so that they wouldn't risk infection of their family. So, you have to like make sure that you're providing like some critical incident stress management to your colleagues and taking care of everybody. And also remember that you're not alone. So in the US, we have NETEC, which is a preparedness partnership for special pathogens, and we have international partnerships. But there's a lot of resources on the website, including all of our protocols. So if that's something that you're interested as you're thinking about developing your protocols, take a look at it. You can ask us questions, check out the email. But it's a good resource, and hopefully European CDC and other organizations are also kind of thinking about some of this. And that's all I have. Questions, comments? We'll use the catch box. Okay. Okay, I'm not good at throwing, so I'm going to bring it. Okay.
I was wondering what sort of policies or protocols you have around nebulizers, and if you know like the evidence of using nebulizers versus inhalers in the ED setting.
Do you mean nebulizing a medication, or do you mean like a physical nebulizer?
Is there a different way? No, sort of a nebulized medication.
From the O2 on the wall?
Yeah, exactly.
Yeah.
Salbutamol or something like that.
Yeah.
'Cause we do that for a lot of our dyspneas as they come in, and they might be doing that in the waiting areas.
Yep.
Without knowing if there's a fever in the background or
Correct.
things like that.
Yeah, so nebulizers, inhalers are like create less droplet, right? Because it's mostly just going into the patient, even if you're using a spacer. The nebulizers do create an aerosol coming out of the nebulizer. So there's different types of masks that can be used. Some that have one-way valves, and others that kind of release more nebulized medication. So that's something we looked at a lot in COVID, was like, how are we nebulizing? We prefer not to nebulize like somebody that's at risk of a droplet or airborne transmitted pathogen. But if they're in a room, the gold standard would be in a room in airborne isolation, but we know that's not realistic. But in a room is like a good first step.
Because it would need to be a room with negative pressure and sort of specific to isolation for it to not continuously spread outwards, right?
Yes, but the thing with a nebulizer is it's creating large droplets. So those droplets are not going to like leave this room, right? They're probably not going to leave the patient room. They have a small 5 feet or whatever that is in meter radius. So they're not going to, it would be okay for a patient to be in a regular room. We try not to do it like in a hall spot or in the waiting room, but it happens. And it depends on the nebulizer device itself. Other questions? Comments? Great. Well, thank you for your attention.